Welcome to Knowing Your Way, a Princess Margaret Ovarian Cancer podcast. Today, we will be discussing chemotherapy as it relates to the disease. Almost everyone who receives a diagnosis of ovarian cancer will go on to receive chemotherapy. Even as a physician who's managed patients on chemotherapy, it wasn't until I received it myself that I began to appreciate some of the misconceptions that many of us have about it. I think that the biggest thing I learned was how many side effects can be managed in order to minimize impacts on daily life. Yes, I'd get tired. Sometimes my appetite wasn't the best, and I experienced moments of melancholy. But there were many days when I was able to be moderately active, to have visits with my family and friends, and I even picked up a couple of new hobbies while receiving chemo. I always felt very closely supported by the team at Princess Margaret, with frequent monitoring of blood work, the occasional CT scan, and regular visits with my oncology team. Today, we're very fortunate to have our guest, Dr. Liat Hogen, a gynecologic oncologist at the Princess Margaret Cancer Centre and assistant professor at the University of Toronto. Dr. Hogen is one of the founding members of the Comprehensive Ovarian Tumors Program at Princess Margaret. Welcome, Dr. Hogen, and thank you so much for being with us today.
Good morning, Alicia. Thank you so much for inviting me. I'm really delighted to help with this podcast. I feel very privileged to be able to help with that.
That's great. Thank you. So why don't we just begin by having you tell us in broad strokes what the treatments are for most of the women who are initially diagnosed with ovarian cancer.
So as you're aware, Alicia, there are many types of ovarian cancer. The most common one is discovered at an advanced stage disease, meaning the disease has already spread outside the ovaries. And then at that point, the treatment can be either going ahead with surgery, and then this will be followed by chemotherapy and later maybe maintenance treatment. Or it could start with chemotherapy first, then have surgery, yes or no, and then have more chemotherapy followed by maybe maintenance treatment. So that's in general for most patients with ovarian cancer. Certain rare subtypes of ovarian cancer will not necessarily require treatment with chemotherapy, but we are talking about less than 5% of the patients.
So the majority of patients will either have surgery followed by chemotherapy or chemo followed by surgery followed by more chemo.
Correct.
In a podcast that we had with Dr. Bernardini on surgery, he described which of the two paths patients will take. Can you review that with us again today, please?
Of course. So that's one of the major decision making when we first see a patient with ovarian cancer. So the patients that is presented to us with high volume of disease, has multiple sites of disease, and is clinically feeling unwell. She can't eat very well. She has a lot of ascites, and she generally deteriorated with her ability to do her daily function, not as good as previously, might not be a good candidate for primary surgical intervention, meaning we are not sure the patient will actually benefit from surgical intervention because it will take a lot of energy from her body to recover from a big procedure, and that will delay her option to get chemotherapy, which is a major component of the treatment for ovarian cancer. So we look at three major things. One is the functional status of the patient. The second thing will be the volume of disease, meaning how much disease there is, because now the disease is not just in the ovaries, it had spread to many sites of the abdomen. It could be involving the bowel, it could be involving the spleen, it could be involving the upper abdomen or even sites in the chest. And at that point, removing all the disease will be not feasible. So So that's the second part. And then how much surgical effort you need to put to clear the entire disease, and even if it's feasible to do it. We know that we cannot live without the entire liver, for example. So if there is disease inside the liver, that essentially exclude the patient from being a good surgical candidate. And at that point, we do recommend on giving chemotherapy first. And then most of the patient, and that's one of the things that is advantage with this type of ovarian cancer, will respond to chemotherapy. So about 70 to 80% of the patient will have good response to the chemotherapy. This will shrink the disease, and then the patient will be probably a good surgical candidate after a few cycles of chemotherapy.
Okay, great. So in summary then, if the patient is having a lot of issues in terms of their general health because of this specific cancer, and or if the cancer is very widely spread, and or if the surgery up front is not felt to have a high success rate, then chemotherapy is given up front rather than surgery up front. And then that chemo may be followed, or is often followed, I guess, by surgery, which is then often followed by chemotherapy. Is that correct?
It's an excellent summary.
Okay,
exactly.
great.
Yes.
And then
just one little comment. Some patients are very, elderly and frail, and surgery upfront will not be a good solution for them. And we also, even the chemotherapy, we need to kind of tailor it to the patient performance status and age. Yeah, so that's an addition.
Yeah. Thank you. And I mean, it's really, really important that listeners understand this whole concept, because as you said, it's one of the big decisions that's made early in the treatment course for every patient.
And exactly for that reason, we founded this ovarian tumor, comprehensive ovarian tumor program, because each and every patient that has this diagnosis is being flagged, and we present all of these patients in our multidisciplinary ovarian cancer tumor board every week. And the entire team, we review the radiology with the radiology specialist, and the entire team give their feedback about should the patient go for primary surgery or for neoadjuvant chemotherapy. And we have very objective criteria for that. Yes. And,
amazing to learn what goes on in the background. Yeah. For every patient that's enrolled in your program. And it's very comforting, I think.
Yeah. And we even published recently our data in one of the major, leading journals for gynecologic oncology. So from our patient population, our experience in this, this program, and the model on how to triage the patient.
Excellent. That's really exciting. Great. So Dr. Hogen, can you tell us generally what physicians mean when they're talking to their patients about chemotherapy? Like, what is chemotherapy?
Yeah, so chemotherapy is a very broad concept, right? And with every, there are many types of medication that are considered chemotherapy, but in really broad strokes, chemotherapy is a drug medication that kills dividing cells. And because cancer cells are dividing very fast, the chemotherapy targets those cells most of the time very efficiently. Because chemotherapy is given systematically most of the time, meaning it's given either IV, sometimes, IV meaning in the veins, sometimes it's given in the abdomen intraperitoneally, IP. It doesn't affect only cancer cells, it also affects all dividing cells in the body. So some cells in the body divide very fast. For example, the hair follicles, the lining of the bowel, the lining of the mucosal, like the surfaces of the mouth, the nails, skin. So those cells can be affected as well. And also the bone marrow cells, meaning your blood, your red blood cells, your platelets, those cells are also dividing very fast. And that's why we get all these side effects from the chemotherapy. And different types of chemotherapy. We have combinations of chemotherapy so it can work better to fight the cancer. But obviously the combination can also cause more side effects. But the side effect profiles is kind of not exactly unique, but more characteristic for certain types of medications.
Okay.
There are many protocols and for many types of disease. So the protocol for lung cancer will not be the same as the protocol for ovarian cancer. And even for ovarian cancer, there's several subtypes of ovarian cancer will have different regimens of treatment. And so I will be happy to discuss the type of regimens that we offer our patients and the type of medications that we are giving.
Okay, sure. Why don't we just briefly summarize then? The chemotherapy can be received by the patient through the veins, by mouth, I think you mentioned.
Yeah, which is, we normally don't give it as the first choice. Those are I just mentioned it as a type of medication, even chemotherapy that can be given by mouth, but most of the time we don't give it for ovarian cancer patients.
Okay, so then primarily the chemo is given through the veins, and often it can also be given into the abdomen. And I think we maybe can talk about how exactly it gets from the bottle or the vial into the veins. I know that I had what's called a PICC line, which is a special kind of intravenous tubing that is very stable inside the patient, that doesn't require replacement very often or at all during the treatment course. You have a model of a PICC line that our viewers on YouTube can take a look at if you want to demonstrate it, please.
Yes. PICC line is the percutaneous intervention catheter, a central catheter. Essentially, I'm going to show it and I'm going to explain. It's essentially done when the patient is given local anesthetic. So the installment itself is not painful. It's done under radiology, so you will get an X-ray and an ultrasound for the person that installed it to put it in the peripheral vein, meaning a vein that is normally in your arm, but it has a long, lumen, and it goes from the peripheral vein, from the arm, into a major vein close to your heart. Okay. And then you won't feel it, but it will be there, and that will enable the nurse to give you the chemotherapy or to take blood test through a device that is already there, and that will spare you, the needle pokes every time you need to get chemotherapy and to get blood tests. So this is the main advantages of this device. I can show it, and if you are going to go on the YouTube afterwards, you can even see it. Okay. So this is a model of an arm, as you can see. But obviously, it looks here. It actually looks much more, robust than in real life. On the patient, it doesn't look like that. And so here you have what we call double lumen. So they have two separate lines here. Most of the time for the chemo patient, we only have a single lumen. And then it goes under the skin into your vein. So you will have this as an outside. So you will still have it outside. It will be, you will have Band-Aid on it, and you will need to have it flushed in the chemo daycare. So that's the disadvantage of the PICC line. And then once you're done with your treatment, it's very simple to take it out. It's not painful at all. Okay. So that's one of the options to get the chemotherapy through PICC line. Yeah. Some patients don't really require that. So many patients just have like their chemo given IV with peripheral line. They will have the IV inserted, every time they go to the chemo daycare. Their veins are they have good veins, but the chemotherapy, we know that the chemotherapy can damage the veins. And yeah. So because the veins in your arms are relatively small to veins that are higher up and we don't see them, it's easy to for these veins to get burned by the chemotherapy and not be accessible later on for further cycles. So another option is just, get the chemotherapy with peripheral vein, just without this device.
Okay.
Another option is to get what we call a portacat. So the portacat, I have an example here. For that, it actually looks like this. It goes under the skin, under the collarbone, about 2 or 3 centimeters under the collarbone. Also done by specialists. You will get freezing before this will be installed, and so it wouldn't hurt. And then this will be installed under the skin, and it will go, the tube will go in the vein, in a major vein. And then you can get chemotherapy from that. And this one is not visible, so it's under the skin. You can feel it. It will be a small pouch, but it's not something that you will have coming out of your arm. And every time to access it, you will get something to freeze the area so the poke wouldn't hurt. And then it will be taken out at the conclusion of the treatment.
Okay. Yeah, so it looks like a little button under the skin, and it feels maybe like a little button that can be accessed after freezing the area a little bit. Exactly. And why would someone have a portacath under that collarbone versus the PICC line, which I think is usually what's used?
Yeah, so it's really up to the patient's preference. So we kind of discussed the pros and cons for both. The advantage of the portacat is that you really don't see it. Nothing comes out of your body. It's under the skin. The disadvantage is that you do need to, the poke is going through the skin yet, so you need to get freezing every time before, so it's less comfortable. And then, otherwise, it's a pretty convenient device to have. And with the PICC line, the advantage is it's out there, and you don't need to be poked at any area in your body because it's very easy to access. But if you want to go swimming, for example, a lot of patients ask about that, you need to cover it, and it's less comfortable because it's coming out of your arm.
Right. I remember every time I went into the shower, I'd have to put this waterproof sleeve on top of the PICC line, and I was always a little bit paranoid that I would get it wet. Not that I think that's a crisis if it occurs, but I was a little bit paranoid sometimes about the PICC line, although I don't think I really needed to be. So that's intravenous, can be through the PICC line, that long IV line that goes into the heart, or a short little intravenous, which I don't think is used very often, or the intravenous can also be.
The intravenous actually, a lot of patients actually get it. But when they feel that they don't like to be poked anymore, or it's very difficult, then nurses need to try a couple of times to get venous access, then we arrange for a PICC line. Okay. It's up to the patient, and when we see the patient in clinic, we discuss that if we see there are challenges with venous access, so we definitely arrange for PICC line or for portacat. All right.
And you also described the intraperitoneal chemotherapy that's given by a port as well. Do you want to expand on that a little bit?
Yeah, so that goes a little bit to the chemo regimen, which we will discuss later on. But essentially, the IP port, it looks the same as the portacat. So the same kind of devices I'm showing here, if you want to see in the YouTube later. The head of it, it's a bit bigger, so it looks actually like that. The head of the port. And this is connected.
Is that the size of a, excuse me, but is that the size of a quarter? Would you say, or
exactly.
Looney maybe?
The size of a quarter, yeah.
A quarter, okay.
That's the device, and then it connects to, obviously it needs to have a tube connected to it. So at the time of your surgery, we, the surgeon or us, we will install it under the skin, normally in the rib cage, like in the mid-clavicular line, so mid collarbone, but lower. So right where your rib ends, it will be under the skin, so you wouldn't see it, but you can feel it. If you touch the area, you will have a little bulge. And this is made out of a silicone, so a needle goes in it very easily. And then we put the tube through your through the access into the abdomen, so this tube stays in your abdomen. And when after you recover from your surgery, you will come to clinic and we will explain about the IP chemotherapy regimen. And this will be accessed when the IP chemo, meaning intraperitoneum, meaning in the abdomen. The treatment will be given through this port by the nurses in the chemotherapy, and I'll explain how. And this is only something we do for patients that had primary debulking surgery, meaning they had surgery first, and that they had what we call optimal debulking, meaning the disease was either completely removed or removed to less than 1 centimeter. And after we finish with this regimen of chemotherapy, we do a small procedure in clinic and remove it. It doesn't hurt, and it takes like 10 minutes to do. That's one option of getting the IP port installed. In some patients, we don't have the actual diagnosis at the time of surgery with the subtype of ovarian cancer they have. And because it's very tricky, sometimes you will have the surgery, and then after the recovery, when you have the final pathology, the surgeon will decide that you will need the IP like that you might benefit from IP chemotherapy, and then it can still be installed, but it will be installed the same way we installed the Portacat or the PICC line by the what we call intervention radiologist department, so it can still be put in even if you had your surgery and didn't have the IP port installed at the time of surgery.
Yeah, I had surgery, and then I had the PICC line as well as the IP port inserted. Both procedures were very unremarkable. I was comfortable. Everyone was very calm, and they didn't take very long to get inserted at all. And I found them to be just fine without any problems throughout the course of all of my chemotherapy. So the chemo was given in a clinic by highly trained nurses. I remember being placed in my own room when I received the intraperitoneal chemotherapy. And maybe we can describe how long the infusions last. I guess it's just in the order of, is it minutes to hours? Maybe you can get into that. And also what makes IP therapy a little bit unusual, actually, in my eyes anyways, for patients.
So that brings us back to the type of chemotherapy and regimens that we give to patients with ovarian cancer. So patients with epithelial ovarian cancer with advanced stage mainly are candidates to be given either IV carboplatinum, this is one medication, and paclitaxel, which is the second medication. So we call it, the medical term is platinum-based doublet, meaning doublet, 2 medication, platinum-based, the carboplatinum. Carboplatinum is the main medication that was shown to be beneficial for patients with ovarian cancer. It started with cisplatinum back in the 70s, where it was shown to be, it made a huge difference in survival for patients with ovarian cancer, and then later on evolved into the carboplatinum, which is another medication from the same family of the cisplatinum, but with less side effects. So that's the main regimen that we're using. This regimen is given IV, intravascular, as we discussed, every 3 weeks. So every 3 weeks, the patient will come to our clinic. They will see the physician, the surgeon, and that also gives the chemotherapy. And then we'll have blood tests. And if the patient is, meets certain criteria based on the assessment, vitals, and blood work, then she's good to proceed with chemotherapy. The chemotherapy is not given on the same day that she's seen in clinic. So that means that the patient goes home after clinic, and then the day after or 2 days after, she will come to where the chemotherapy is being administered, being given. And that's usually in chemo daycare, which is in the same building of Princess Margaret, but in the chemo unit. So at that unit, you don't see the physician, you will see the very experienced, excellent chemo nurses that we have there. And obviously, if there is anything that the doctor needs to be, informed about, or if the nurses have questions, they page us and there is like a fellow that covers the chemo daycare for any, problems or questions.
Okay.
But the nurses are very proficient, and they really have a lot of knowledge, and they know what to do. And when the patient is being seen in clinic bus, we actually put the chemo orders already for the nurses to execute on the day of chemo. And we also send the pre-medication, which we'll talk about, to help with the potential side effects of the chemo to the patient's pharmacy of her choice. And then, so that's one of the regimen, the carboplatinum and paclitaxel, that's given IV every 3 weeks.
Okay.
The other regimen that we discussed, and you mentioned it, Alicia. So there is the IP intraperitoneal regimen. So when we say IP, it's not just IP, it's given IP and IV. So this regimen is a bit more complicated, because essentially you get day one. So you get chemotherapy on the first day, which includes IV paclitaxel and IP intraperitoneal cisplatinum. So that's the day one of treatment. And then on the same cycle, you have the day 8. So a week later, you need to come to chemotherapy, chemo daycare again, and then they will get their IP paclitaxel. So, and that concludes one cycle of treatment.
Okay.
So day 1, day 8, and then after 21 days, the patient will get her second cycle. So she will come again to see the clinic 3 weeks from her day 1, assessed with blood work, and then again, 2 days later, IP day 1, and then day 8, IP as well, with the same regimen that I described. So that comes every 3 weeks.
Every 3 weeks?
Yeah.
And typically, how many of those 3-week cycles are given?
So for patients that had surgery first, normally they will get 6 cycles after surgery. For patients that had neoadjuvant chemotherapy, meaning had chemo first, so chemo first is only given IV. We don't give IP chemotherapy first. So they get 3 cycles, and then they will have CT scan, and then most likely they will have the 4th cycle of chemotherapy, and then about 4 weeks or 5 weeks later, they will get surgery most of the time. And then after surgery, they will either get 2 or 3 more cycles of chemotherapy.
Okay.
So a total of about 7 for those patients. And then for as I mentioned, for patients that had the IP, I haven't mentioned it yet, but sometimes we combine cycle of IV. So some patients right after surgery that are candidates for IP can get like 1 cycle of the regular IV carbotaxel. And then for the following cycle, they will start the IP regimen.
All right.
So, so we make this combination of treatment for, and that's our main protocol. Some patients have a lot of other, medical issues, or they are elderly, or their functional status is really, challenging, and from various reasons, we can sometimes consider giving a single agent, meaning one medication, and that will be the carboplatinum.
Okay.
And then obviously down the road, there are other medications that we can give in a different type of regimens, such as giving Taxol every week in low dose, or with Avastin. There are other types of medication. I don't want to start, if we need to go into all the details.
But I guess the message would be that while there are much more common protocols that are used, that there are always options to modify the protocols according to the health and the wellness of the patient, that you can tailor the treatments according to all of the information pertaining to that patient, which is, I think that's very hopeful for any patient going to the clinic. Yeah.
Definitely.
And just, when I'm not sure if this is done still, I imagine it is, but when I received the IP treatment through the port that was placed under the ribs, that I was lying on a stretcher, and I would have my whole body tilted with my head down and my feet up, and then my whole body tilted with my feet down and my head up, and then I would be rolled from one side to. I felt like I was a chicken being basted or something.
Yeah.
That was weird.
Chemo daycare, so normally the IP patients will be in a private room. Because of that reason, there is a special bed that you can actually tilt, and it's bigger than the usual bed. And so that's why the IP patients are usually put in a private room. And yes, like you described, because you get a lot of medications the patient gets the medication into the abdomen. We want to make sure that the chemotherapy goes everywhere it needs to go. So that's the kind of manipulation that we do from side to side, up and down, I ride the hospital bed. But that's very unique just to the IP.
Yes.
But when we talk about, like, in general, when a patient comes to the chemo daycare, specifically for the first 2 times, it can be a very long day. And the reason for that is A, you're getting 2 medications, and B, one of the medication that you're getting, which is the paclitaxel, needs to be given very slowly to prevent what we call hypersensitivity reaction, which is like an allergic reaction, but it happens immediately with the chemo. And also, in order to prevent this phenomena, which can happen very frequently, there are many pre-medication that are given by the nurses in the chemo daycare, such as steroids, such as Benadryl, and also famotidine, which is histamine blocker that can prevent allergic reaction. And those are given before the chemotherapy, before the paclitaxel. They also need to be given with hydration. And so the whole day is a very long day, and patients need to be aware of that. And that goes for the IV treatment. With the IP, it's even longer, because you get this regimen, plus they get the saline that goes in the abdomen before the chemo is given in the abdomen, and they also need to get IV hydration to prevent side effects to the kidney, so renal toxicity, kidney injury. And so we have all these other medications that are being given on top of the chemotherapy to help mitigate potential side effects and injury to other organs. And so a long day in the chemo daycare.
It is a long day. And to that point, then I remember initially observing other patients receiving chemo in the clinic, thinking, wow, they're so organized. They've come with their slippers and their blanket and their book, or their music and earphones or headphones, because they knew that they would be spending a fair amount of time there. They wanted to be comfortable. And they wanted to be distracted, I would think, while getting the chemotherapy. So it's something for listeners to think about too, what they want to bring with them in order to feel comfortable. That would also include snacks, because, after a while, what you can get downstairs at Princess Margaret gets a little bit boring. You can't have Tim Hortons every time you go to chemo, although I like their chicken noodle soup. But you might bring something from home that's more, more comforting to you, that you like specifically.
Yeah, and that's an excellent feedback, because, we see the patients in clinic. We don't always see them in the chemo daycare, and even to clinics, patients come with a lot of, equipment, such as what you suggested, books, headphones, a friend. Yes, it is a long day, and you need to think about all the things that make you feel comfortable, right? Because you want to feel comfortable on that important day. And there are a lot of, you will see a lot of people with the nurses coming in and out, and then medical care, and then many medication that goes in. So it's a stressful day, so you want to make yourself feel as comfortable as you could in this situation.
Yeah. Okay. So I think you've already mentioned some of the side effects. Why don't we continue along that line? So you talked about the hypersensitivity reactions, and you talked about how the bone marrow can be affected by the chemotherapy drugs. You've talked about the kidneys that can be affected. You briefly mentioned something we call peripheral neuropathy. Do you want to expand on that a little bit, Dr. Hogen?
Yeah, definitely. So with this specific regimen that we are giving for the chemotherapy, there are side effects that can be from the carbo or from the Taxol or from the combination of both. When we talk about the paclitaxel specifically, one of the major side effects is the fact that this medication can cause some numbness sensation in the tip of the fingers and in the toes. And if this gets worse, it can actually, it can start going into other areas, even the entire hand or up to the knees, and can actually affect the balance and the ability to sense the floor that you are walking on, and that can, increase the chances of having falls, etc.
Yeah.
So that's why, and this is called peripheral neuropathy. So that's one of the reasons why we assess the patient in clinic prior to each cycle. And by our questions, we know if the patient started to experience this side effect, and if so, how severe it is and how do we address it. So some patients will need to reduce the dose of the paclitaxel. With some patients, it's so severe that we'll need to stop it and maybe consider changing it to docetaxel, which is Taxotere, which is another medication that is from the family of the paclitaxel but has less potential for neuropathy. We can sometimes treat with medication that can help with peripheral neuropathy, such as gabapentin or Lyrica, and we can explain to the patient about that. And also for patients that are getting IP, the cisplatin itself that's given IP can also cause peripheral neuropathy, which is more severe than just having the paclitaxel. So the combination can be quite toxic to the nerves. So we need to adjust better our regimen or our dosages for the patient, because we don't want to compromise the ability to walk and function when the patient is on chemo. And this is one of the side effects that is not always completely reversible. So that's why it's something that we really pay attention on when we assess the patient. Whereas other side effects that we mentioned, so for example, the carboplatin can cause low platelets. So it's something that we check every time. And if it's too low, we need to postpone the treatment in 1 week, and we see the patient again, because we have to give the bone marrow time to recover. And obviously with a combination of treatment with the paclitaxel, both of them together can affect the bone marrow, meaning the area of your body in your bones that actually produces the blood cells that are essential for the immune system to function, for hemoglobin to be produced, and for the platelets to do their job with clots of areas if there is bleeding. We always monitor that, and we know chemotherapy can affect that. As you mentioned, effect on the kidneys, which we always monitor, and we can adjust the dosage if needed. Other side effects, so the carboplatin or the cisplatin will not cause hair loss, for example, whereas the paclitaxel is causing complete hair loss. So most patients will start having the hair loss right after their first cycle. Not like most of the patients won't have complete hair loss after one cycle, but with more cycles, they will experience more and more until, all the hair is lost. But it starts growing back again, as soon, like right after you finish when you finish your chemotherapy. Usually within 4 weeks after the last cycle, the hair bud starts growing again.
Obviously, hair is important for most women, and I think it can be pretty traumatic when you see that you're losing hair. I think many women, including myself, choose to either cut their hair very short initially, or just have the hair removed by way of shaving the head. And I know that, it's something that women going through this think about a lot. And I think that it's good to reach out to maybe other people that have gone through the treatment, or your nurse, maybe your physician, about the hair loss. But to remember that it will come back. And, we talk about it coming back in different ways, maybe much curlier than it used to be, or maybe a different color, a different texture. But we have to think about this being a temporary state, and that it is part of the means to get to the end, which means better health. And I do remember purchasing a wig. I had an insurance coverage, and the cost was partly covered by the insurance plan. I found it very warm, and so I actually didn't wear it a lot. I sometimes wore a scarf, but not all the time. I know that some women think about wearing cold caps, what we read about, online. And I understand that many women choose not to. I think from what I've read, they can be quite cumbersome in terms of placing this cold cap around the head tightly, through which water, very cold water, is circulated. And the thought is that the follicles of the hair will be, or the blood flow to the hair follicles is reduced, so the chemo doesn't reach the hair follicles. But from my reading, it looks like the success rate is not guaranteed by any means. And I just wanted to touch on it because I know some women do ask about cold caps. Now I'm sorry, I kind of interjected on the cold cap thing before you were going to talk about other side effects. We haven't touched on the nausea and vomiting, sometimes diarrhea that can occur. Do you want to expand on that?
Yeah, so you summarized the hair loss quite well, and we do see patients that choose to, cut their hair. There will be sometimes hair loss even of the eyebrow and the eyelashes. So that's, many patients just mentioned it to me that it was even more difficult than losing their hair. Because for the hair, you kind of have some solution, even though I know as a woman, it's how hard it is to lose your hair. It's really something that you change in front of yourself, and it, it's something that can be traumatic, as you said, but it grows back, many times curly, as you said, but it grows back. And you already summarized the cold cap, question and sort of option, yes or no. So if we move forward towards the question about the nausea and the vomit and the other side effects. So I find that the most common side effect all patients mention is the fatigue and lack of energy, which is very profound in many patients. They will tell me that in the first week, they were, not all of them, obviously, like it's just one of the most common side effects. The lack of energy and fatigue is something that they're not used to. They are healthy young women most of the time, and then they are fully functioning, and then all of a sudden they can't do their work. They can't, in the household, like with their kids or with their families, it's more difficult for them to function. You don't need to function the same way. You are now on treatment. It's not expected of you to be the same. Do whatever your body agrees to. Use your energy to do things that your body enjoys doing, you are enjoying doing, and that will improve. So with the more chemo you get, you will feel most of the time more fatigue and more tired, but eventually it will take a few good months, even up to a year after you finish your chemotherapy, to go back to your baseline. But it's completely normal. And for that, we don't have a lot of good solution other than really take your time to relax and do things that your body agrees with your body. The other thing is you mentioned is the nausea and vomiting. So with the IV carbotaxol, this is very, it's not a very common side effect that the nausea is something that you can't function with, because we have excellent medication to help cope with that. You will get it on the day of chemo, you will get it right after chemo for a few days, and then if needed, you will get it when you have, when you have nausea. And this is very helpful. And then vomiting is really not common with our regimens. With the IP, patient gets more nauseated, and so we have every patient that gets IP chemotherapy gets IV home hydration, meaning the nurse will come to her home and give her fluid IV after the day one for 3 days at home to help cope with those kind of side effects. And if there is a limited oral intake, so meaning you can drink enough to supply your body with the fluid that you need. So we have it in place for the patients. And for the other side effect that you mentioned, and it's something that is common, the bowel movement changes. So some patients will have constipation where others will have diarrhea. So that's also something that we have the MBO program, malignant bowel obstruction program, even though it's not about obstruction, and the nurses know how to educate the patients about what to take to help with the bowel symptoms when they are on chemotherapy. We also have a very good chemotherapy class sessions. Before you start the chemotherapy, you will get a session with very experienced nurse about all the potential side effects, how to address, who to contact, what to do. So that's very helpful as well. Other side effect that is kind of frequent but not as frequent is just muscle, bone, and joint pain after the chemotherapy. This is a transient side effect, but it can sometimes be very profound. And for that, we give Tylenol or even hydromorphine if the pain is really significant. So that's another thing that we ask the patient, and the patient will tell us, and we help them to manage. But this one is not long-standing, as opposed to the peripheral neuropathy that I mentioned before.
Right. Yeah. It's interesting that you mentioned that the fatigue can last even months after the chemotherapy has been given. And I do remember going back to work and thinking, oh, my energy, especially during the afternoon, is not what it used to be. And I was a little bit concerned, because I was finding it difficult sometimes to get through the day. But I did realize that over time, after the effects of the chemo wore off and I became more fit and more strong, that I was able to get through the day with much more stamina. The one thing that I worried about quite a bit was something that is referred to as brain fog. Everybody worries about any effect on your cognition, on your ability to think and make decisions. As a physician, I was quite concerned about that as well. And sometimes I wondered if I was experiencing some brain fog. I'd like to think that it wasn't too bad, after the chemotherapy was completed. Do you want to talk to us a little bit about that?
Yeah, I found that, some patients mentioned that to me, that they're not as, I would say, as sharp as they were before they started on chemo. And the memory might be not the same. The processing time is longer when they're on chemo, and it's a known phenomena. For most patients, it resolves. It takes a little time, but after completion of the chemotherapy, and I think it creates a lot of anxiety, as you mentioned, because for patients that have a lot of tasks to do around the house, and she needs to remember this and that and that. It's important to function like this. For patients that are physicians or have other work outside the house, it's something that obviously you need your cognition function to be as good as it was before. But I think knowing that it's something that many patients experience with chemotherapy, and knowing that it will get improved after you finish the chemotherapy is reassuring. We also have the survivorship clinic in Princess Margaret, which helps patients to cope with any of the kind of long-standing side effects of the chemotherapy, such as brain fog, for example, or joint problems, or neuropathy, or even like psychosocial, like the difficulty to cope with something that, change your life completely. You don't feel the same. You're not the same. You don't know if you will ever be the same. And just like living with the notion that you have like a disease that is many times can come back. And knowing that and living with this, this information in your head all the time is very difficult to cope with. And so we do have this psychosocial support and areas where we as physicians are less competent to help with, but we definitely have our survivorship clinic where there are a lot of services that can help the patient cope with those issues as a survivor or survivors of cancer.
It's really good to know about, yeah, for sure. To have that resource available for patients, as well as I know that you're building online resources within the program, and we're developing this podcast as well, which will help patients coming through the other end of the chemotherapy and surgery treatments. And can you tell us, Dr. Hogen, how it is that progress is monitored? You know, we go through all of this chemotherapy. It's a big commitment, I think, that the patient and the team is making. So how do we know if it's working or not?
That's an excellent question. So first of all, when the patient is on treatment, we always monitor the blood work, which includes most of the time CA-125. CA-125 for many patients with this type of ovarian cancer is a good marker of disease activity. And if we see that the marker is trending down as we expect it to, we know that the disease is responding and shrinking and disappearing. At the conclusion of treatment, whether it is surgery first followed by chemo, or if it's chemo, surgery chemo, we will always do a CT scan to see what is the status of disease. And at that point, ideally, we want to see no evidence of disease with the CT scan. And then for patient after so that's in general, but I just want to mention that for patients that had neoadjuvant treatment, before we decide to yes or no go for surgery, we also do a CT scan in the middle of the treatment to see the response, if they are good candidates for surgery at that point.
Okay.
But anyways, at the conclusion of the entire treatment after the last chemo cycle, normally within 3 or 4 weeks after the last cycle, we will have a CT scan to see if there is any residual diseases or no. Normally, a lot of the patient will have maintenance treatment after completion of the bread and butter chemo, surgery chemo. And then depending on if yes or no, they're on maintenance treatment, the follow-up is changing. So for example, patient that is not on maintenance treatment, after the CT scan, the last CT scan that she had after completion of treatment, we will monitor her every 3 months with blood work of the CA-125, if that was a good marker for her, and with physical exam, and with obviously questions about symptoms. And we always tell the patient, if you have any new symptom that might be of concern to you, you can call our office or the nurse line and let us know, and we'll decide if we need to see you sooner.
All right.
So that will be every 3 months with CA-125. And then for patients that we see that the CA-125 is rising, this is when we will order a CT scan. Because the marker is just like a sign of the disease activity, whereas the CT scan is actually showing you if there is disease, yes or no. And that's more specific, but obviously we can do CT scan every 3 months because of many other potential problems with many CT scans. But then the CA-125 is a really good marker for most patients. And patient on maintenance treatment, something else, because you need to see them more frequently to monitor that there are no side effects as a result of the maintenance treatment that they are getting. So they are still on active treatment, but not with chemo, but with biological treatment.
Okay. And just for our listeners to know that we are planning an episode on this maintenance therapy, which is what Dr. Hogen is talking to us about right now, the drugs that are given after that so-called bread and butter traditional chemotherapy that's given earlier in the course of the disease. Dr. Hogen, you mentioned that if the patient has any issues after the chemotherapy, that they can contact the nurse clinic. I would assume that they can easily contact the nurse clinic while they're receiving chemo too. Can you tell us about that?
Yes, definitely. So we do have a nurse line that is always available to all our patients in Princess Margaret when they're on treatment, or when they come to clinic and they go home and they forgot to ask the doctor something, or they forgot to they have a new symptom, and there are many reasons for them to contact. They're not sure about their schedule, so there are certain numbers they can call and speak to a nurse. Even if it happens in the middle of the night, there is a care path number, so the nurse line will have a number to refer you to it. You will have somebody always available to you, and this the care path nurses, even in the middle of the night, they know how to contact the physician. And obviously, if there is something that is acute and the patient feels really unwell, they can always go to the emergency department. But there are resources to help with things that are less acute and can manage over the phone. And sometimes they will tell the patient, just come to clinic, somebody will see you if it happens in the, during the daytime, because they will contact the physicians and will give them, instruction about what to do next. And those nurses on the nurse line, they are the one that they work with us every day, and they are very experienced and they're very good. And we also have for patients that are, in the ovarian cancer program, they can also contact our nurse navigator from the program, and we also provide the number for her.
All right. So patients should never feel alone, even if they're not living close to the center. They will always have some kind of support system they can go to should they run into any problems. Well, I think we've covered a lot of ground. I just wanted to add one little thing that I forgot about the HIPEC, which is another. Oh, yes.
Something that patients ask a lot about, and we are actually the only site in Ontario that offers HIPEC treatment for patients with ovarian cancer. So HIPEC is heated intraperitoneal chemotherapy, and this chemotherapy is given at the time of surgery. So the patient is asleep, we do the surgery, and then when the patient is still asleep, we install the chemotherapy into the abdomen. We close the abdomen, we shake the patient and then we drain the chemotherapy, and then we finish up the surgery. This is given only for patients that had neoadjuvant chemotherapy, had responded to treatment, and then had what we call interval debulking surgery. And at that time of surgery, they can have the HIPEC, the heated chemotherapy that is given into the abdomen. And so we have that available to our patients. And we are essentially the only site in Ontario that have the option to do it for the patients, but it's only for very selected group of patients. So not every patient that had neoadjuvant is eligible to get it.
Okay, yeah, that's really interesting. So HIPEC, HIPEC, and it's the heated chemo that is installed in the abdomen at the time of the surgery for patients who have received some cycles of chemo before the surgery itself. And I don't know very much about HIPEC, of course. I assume that when you mention that there are a select group of patients that will benefit from it, this is based on previous experience and or studies that have been done in the past to address this question?
Yeah. So there was a very big randomized control trial, which is considered to be the best clinical evidence of benefit. So it was done in a very good methodological way, and it was published in the New England Journal of Medicine, which is one of the best journals to have your publication publish that. It's a Dutch study, and that showed that for certain patients, for certain age group, certain disease that was stage 3 and not stage 4, that had good response to the neoadjuvant, patient that had HIPEC at the time of their interval debulking surgery, had overall survival benefit from having this procedure. But again, only for this very selected group of patients. And our lead for this program in our institution is Dr. Bouchard-Fortier, that raised this project, and we are offering that to our patients if they are fit to, if they answer the criteria, they're eligible for it.
No, that's great to know. It's very, very interesting. So, I mean, I could keep asking you lots and lots of questions for another hour, but I think we need to bring the session to a close. I wanted to thank you very much, Dr. Hogen, for explaining everything so well with us and for patiently going through the details of what can seem like a pretty complicated process, I think, for a new patient to the program. I want to, I guess, just state that I hope, and we all hope, that by listening to episodes like this and by acquiring this kind of knowledge, that the listener's anxiety will be allayed a little bit, so that with less anxiety, more comfort, you can make better decisions, be more mindful of what you're going through, ask some questions, and have the experience be less intimidating than it otherwise might have been. And always know that you're supported by the program, as has been made very clear, I think, throughout the course of this podcast. And I'm looking forward to sharing another podcast with you in the near future. Thank you very much to Dr. Hogen, to Tara Almasi, the program coordinator, and to Matt Proctor, our technical support for this podcast.
Thank you so much, Alicia. I think you're doing an amazing job with that, and the podcast is it's a great contribution to our patient, and just to give your excellent question and your perspective, and I think it's very helpful for our patients, and so thank you for that.
No, I really appreciate the feedback. Thanks.